Welcome to our second video on seizures. Let's get started. Here's an overview of the topics that we're going to discuss in this lecture. We're going to start by discussing differential diagnosis. So here's a table with some conditions that can look like a seizure. Psychogenic or pseudoseizures are seizure-like episodes, but they have a psychiatric origin. Key features of pseudoseizures include the absence of tongue biting and the absence of urinary or fecal incontinence. And patients are often seen having their eyes closed with their bodies moving side to side during the episodes. There's actually no abnormal activity on an EEG during these episodes, which makes sense because it's a pseudoseizure. Let's move on to syncope. This is another condition that can mimic a seizure. Etiologies include a vasovagal and cardiogenic syncope, orthostatic hypotension, and carotid sinus syndrome. So for these, you're going to look for triggers. Triggers like positional changes that might indicate orthostatic hypotension, an emotional stimulus that could trigger a vasovagal syncope, or a history of pressure on the carotid sinus that could indicate carotid sinus syndrome. And the history you're looking for is something that put pressure on the carotid sinus right before causing syncope. So you're not asking, was there ever a time in your life in which somebody hugged you really tight around the neck? You're not asking about that. You want to know right before you fainted, was there anything constricting your neck? Now, abnormal ECG findings can aid in the detecting of cardiogenic causes of syncope. For example, a complete AV block in a Stokes-Adams attack. Now let's move on to breath-holding spells. These are episodes that are triggered by strong emotions like anger or pain, and they can be mistaken for a seizure. And those usually occur in children between the ages of 6 months and 6 years. You're not expecting an adult to do that. I typically just think of a little toddler just clenching their fists and squeezing their little face together and not breathing, and they're just so mad. That would be a breath-holding spell. And those can look like seizures because those can present with muscle stiffness and jerks. Now, during those episodes, children also experience cessation of breathing or apnea, and that can lead to loss of consciousness as well as cyanosis and pallor. But just remember, that's a benign condition and only needs reassurance and patience to let the kid get older than 6 years old. Now, inattentive staring spells is actually considered normal inattention, and it's usually observed in children due to boredom, and they usually occur during boring activities, at least those activities that a child would consider boring. And those can actually be confused with those staring spells that characterize absence seizures. So with these inattentive staring spells, remember that they don't have any automatisms, and the children can actually respond to vocal or tactile stimuli. You can just shake them. You're like, hey, pay attention. I was talking to you. Put on your shoes. And then they can snap out of it and look at you again. That's not something that you could do if a patient was having an absence seizure. And just remember, there's not really a case where a child is so bored that they literally cannot respond to you consciously. You can always do something to get their attention. That is, if we're not dealing with an absence seizure, we're just dealing with a staring spell. Okay. Lastly, it's important to keep in mind that psychological conditions such as panic attacks and psychogenic hyperventilation can be confused with a seizure. And symptoms that may indicate a psychological condition include the presence of tachycardia or hyperventilation. So we're thinking high heart rate, high respiratory rate, diaphoresis, and feeling short of breath. Okay, we just went through a really heavy table. There's a lot of meat in it that you want to remember. So let's break this up really quick with an important question. A 16-year-old girl was hospitalized because of multiple episodes of loss of consciousness and jerking body movements. She does not recall the episodes and denies the presence of any aura. Laboratory studies are all normal. During her hospitalization, she experiences another episode where the nurse noted the patient's eyes rolling backwards and her body swinging side to side before falling to the ground. She also noted repetitive, violent jerking of all limbs. The patient did not experience tongue biting, nor fecal or urinary incontinence during the episode. What is the most likely cause of this patient's condition? Okay, so we've got a 16-year-old hospitalized girl, multiple episodes of loss of consciousness, and her body movements were jerky. So that raises the suspicion of seizures. And during her hospitalization, there were side-to-side body movements, but there weren't some of those other features that are common to seizures, like tongue biting or incontinence. So with those details, you're thinking more of pseudoseizures or psychogenic seizures. And if you employed an EEG, during one of those episodes, it would be normal. Okay, now let's discuss management of seizures. General management of a seizure includes removing objects around the patient to avoid self-injury. Also, you want to do what you can to help maintain a patent airway, and that does not include shoving your fingers in the patient's mouth. So I'll tell you what you want to do. What you do is just see if you can help them lay down and maybe even on their side. But even that's not totally necessary. What you want to do is watch their airway. You're also going to be watching their breathing and circulation, so the ABCs. And that makes sense. You've got a patient that lost consciousness. You want to keep them from hurting themselves, and you want to take care of the ABCs, just like in any patient, always the ABCs. And one of the best things you can do to maintain proper ABC function is by giving oxygen and starting IV fluids. And also, you're going to want to monitor vitals, such as the patient's temperature, their blood pressure, and oxygen saturation. Now, patients with a first-time seizure who have no known history of epilepsy, they actually have a low risk of a recurrence. It's as low as 15%, actually. That is, if they have a normal EEG by the time they're in your clinic. So in those cases, an anticonvulsant is not usually required. However, if the EEG or brain MRI are abnormal, then pharmacotherapy with antiepileptics can be started. Oftentimes with these first seizures, if you can identify an underlying cause and eliminate and treat that, then that's usually sufficient to prevent any recurrent seizures. Now, managing febrile seizures depends on whether they're a complicated febrile seizure or uncomplicated. Uncomplicated febrile seizures usually require no treatment, only reassurance, and they spontaneously resolve within less than 5 minutes. For complicated febrile seizures, those that last more than 5 minutes, or for more complex febrile seizures, then abortive therapy with IV benzodiazepines, particularly lorazepam, is a first-line treatment. Now, alternatively, buccal or intranasal benzodiazepine can be used if you can't get that IV access. And that's important to remember because oftentimes these febrile seizures occur in little kids in which it's hard to get IV access quickly. Now, after that, follow up with an antipyretic treatment such as acetaminophen or NSAIDs. You can use that as supportive treatment to bring the temperature down. Okay, now patients with a recurrent focal seizure and you don't know the cause, you're actually going to manage them first line with lamotrigine, phenytoin, or carbamazepine. And sometimes in children, you can see phenobarbital being used. When it comes to patients with recurrent and generalized seizures of unknown cause, then your management actually depends on the specific type. For example, a tonic-clonic seizure would be managed with first line as valproate or lamotrigine, and then again, phenobarbital for children. And then second line, you can use carbamazepine. Now, if it's an absent seizure of the typical variety, then you can use ethosuximide or valproate. And for all other types, for example, a myoclonic seizure, atypical absent seizures, you're going to manage those with valproate and lamotrigine as first-line treatments. Now let's discuss how you would manage a patient who does have a known history of epilepsy. Now, seizures in this patient group actually occur mostly due to medication noncompliance. So a loading dose of their medication should be administered, followed by maintenance of their regular dosage. And of course, you want to make sure that the medication noncompliance is the issue, and you can get a drug level. So you measure their serum drug level to see if they're in the therapeutic range. So assuming that, then you'd load them up and maintain that regular dosage. And the main treatment principle to remember is that if the seizure persists after adequate compliance with their medications, then you can increase the dose. And that's super logical. Test their serum, think, oh, that's strange, you're still having seizures, and you're taking your drugs, I verified it with serum drug levels. Well, let's increase the dose. Very logical. Now, if toxicities occur due to that increased dosage, then you can actually move to another antiepileptic. So just trust your own logic as you're thinking through this. And on the plus side for these patients, after 2 years of being seizure-free, you can actually try tapering down that medication. And if the seizures don't return after that, then the patient can stay at a lower dose or even get off the seizure medication. Sometimes that happens. So again, 2 years seizure-free, try tapering it off. Now let's discuss other medical therapies that can be used in managing seizures. So vagus nerve stimulation is a procedure where a device is implanted under the skin in the chest region, and that actually provides impulses through the course of the vagus nerve to the brain. And this procedure actually aims to stabilize the abnormal electrical activity of the brain. Now, surgery can oftentimes be indicated if there's a specific part of the brain that's causing all the seizures and it's removable. For example, an anterior temporal lobectomy can actually treat intractable temporal lobe seizures. And a hemispherectomy can actually get rid of the area of the brain with that epileptogenic focus. Now, here's an image depicting that vagal nerve stimulation. Notice the stimulator that's implanted under the patient's skin. And this is in the chest area. All right, now let's do a question. A 5-year-old girl is brought into the emergency department because of a seizure that has been ongoing for 5 minutes. Her parents state that she has been having a high fever due to an upper respiratory tract infection. Her temperature is 39.7 degrees Celsius. What is the best next step in management? Okay, so this patient had a seizure in the context of a very high fever. So at the top of our differential, we're thinking a febrile seizure. But she's been seizing for 5 minutes. Therefore, it requires abortive therapy with IV lorazepam. And you may recall that febrile seizures are usually uncomplicated and they resolve on their own within a few minutes. But if they're going on for longer than 5 minutes or they're complex, then you need to abort it like this with IV benzos. And outside of the acute seizure setting, you got to make sure you're giving the patient antipyretics. You want to help that patient get their temperature down to reduce the likelihood of another febrile seizure, at least during that patient's acute illness. Once they get past that upper respiratory infection, then they don't need to stay on NSAIDs or acetaminophen or anything like that. You just want to keep their temperature normal during their illness. Now let's talk about status epilepticus. Sometimes if you're talking to neurologists or neurology residents, you might just hear the term status. So in the case of a patient in status, this is very critical. You need to rapidly identify that they're in status, and you need to assess them neurologically. And once you've made this decision, think, okay, this patient is in status. We need to stop it. So where do you start? Well, you can start with getting them IV access, give them oxygen, glucose, and even thiamine. However, the most important part is that pharmacologic intervention. So a benzodiazepine. Again, you need to abort the seizure. You're not expecting oxygen or glucose or thiamine to do anything to stop the seizure. You need to stop it, because if it goes on for longer than 5 minutes, it's really damaging to the brain. Now, what is that pharmacologic intervention? Well, we've talked about the first line, benzodiazepines. Well, we talked about lorazepam before. You can also use diazepam. And if you can't get IV access, then you can actually administer diazepam in a rectal form. And then we actually mentioned this before, but also in the absence of IV access, you can use a buccal or intranasal route. So in those instances, you're thinking of lorazepam or midazolam. Okay, so let's say you've tried that. You've tried the first line benzodiazepine. And 1 minute after doing that, there's still no response. So at that point, what do? Well, you can add another dose of benzodiazepines. Then still no response? Then you need to think of an anti-epileptic drug. And there are many of these. One that you might choose would be thiopental or propofol. At the institution I'm at, propofol seems to be used more than thiopental. And then, of course, if you're going to anesthetize this patient, you need to intubate them and admit them to the ICU.
A 7-year-old male presents to the emergency department with confusion and amnesia after a sudden loss of consciousness, followed by generalized muscle contractions and muscle twitching. The patient's mother stated that his eyes seemed to roll backwards as he was shaking, just like the last 3 times this happened. Upon closer inspection, it is noted that the patient has bitten the side of his tongue and urinated on himself. Vital signs include a temperature of 98.8 degrees Fahrenheit, heart rate of 125, a respiratory rate of 22, a blood pressure of 140/100, and an oxygen saturation at 96%. What is the best choice for the medical management of this patient? A. Lamotrigine, B. Lorazepam, C. Ethosuximide, or D. Phenobarbital. So in this question, we've got a child. It's a 7-year-old male. He has confusion and amnesia after a sudden loss of consciousness. And during that loss of consciousness, there were what sounded like a seizure, muscle contractions and twitching. So that should make you think of a tonic-clonic seizure because of those muscle contractions, which actually represent the tonic phase. And then the muscle twitching would represent the clonic phase, like clonus. So tonic, contracting, and then clonus, tonic, clonic.
and the patient's current confusion and amnesia represents the post-ictal phase of the seizure. Additional support for the diagnosis of a tonic-clonic seizure includes those rotated eyes, they seem to roll backward, and bladder incontinence. And the vital signs show the expected increase in sympathetic tone, so there was that tachycardia and hypertension. And often during a seizure, breathing patterns are disrupted. So after the seizure, you would expect a lower saturation with increased breathing. So he had slightly lower oxygen saturation. Not bad, still normal, but it's not 100%, and his respiratory rate is a little high. Now, since this child is having recurrent tonic-clonic seizures with the cause unknown, because we heard that this happened 3 times just like this, then the best medical management would be phenobarbital. So that would make choice D correct. Now, answer choice A is wrong because even though lamotrigine is the first line for recurrent tonic-clonic seizures, phenobarbital is actually the first line for children. Now, answer choice B is wrong because benzodiazepines are indicated in the management of complicated febrile seizures, not recurrent tonic-clonic seizures. And answer choice C is incorrect because ethosuximide is indicated in the management of the typical absence seizure, not for this type of tonic-clonic seizure. And that concludes this section.